Sure. So, good afternoon from, I don't see anyone from venue, but good afternoon from different places. I am Dr. Uday Koirala from Kathmandu Hospital and chairing this session. We have our friends from surgery department and also our engineers who are helping us. So I think they will do their introduction. From Rosen, please.
Hello, everyone.
Pratik.
Hello, my name is Pratik Dutta.
He's our new IT officer.
Good afternoon, everyone. I am Dr. Loken.
Good afternoon, everyone. I'm Dr. Amit Mani Upadhyay.
Good afternoon, everyone. I am Dr. Sachin Giri.
Good afternoon, I'm Dr. Ashok Kumar.
Namaste, I am Dr. Sandesh.
I am Kush.
So I'll move to Sudhin ji. Can you please introduce yourself?
Hi everyone, my name is Sudhin Kansakar. Here from the UK right now, and I've been working in the healthcare sector for 15 years, particularly on analytics and digital twin. Have vast experience within the UK, US, and GCC countries.
Thank you. Nirajan from NREN.
Hello everyone, my name is Nirajan Parajadi. I'm working in Nepal Research and Education Network NREN. Thank you.
From Tendek.
Hello everyone, I'm Shintaro from Tendek.
Thank you. Jivan.
Hello everyone. I'm Jiban Yopani. I'm the CTO and co-founder of AI Lab Private Limited, and I'm working on the telemedicine project along with Dr. Uday. Thank you.
Thank you. Vikas Nirola.
Good afternoon, everybody. I'm also working on the same project along with Zivan for telemedicine for rural health. So I'm on the engineering team for that project. Thank you, everyone.
Thank you. Dr. Moriyama.
Hi, everybody. This is Dr. Tomohiko Moriyama from Kyushu University Hospital. I'm chair of this medical working group, so I'm so happy to be here with you guys. Thank you so much for your participation.
Thank you. Neeraj.
Good afternoon. Namaskar. I'm Neeraj Asare. I'm from Nepal Research and Education Network. Thank you.
Thank you. Thank you, everyone. So this time our theme is digital health strategy in rural healthcare. So I can see Bipin also. Bipin, can you please introduce yourself?
Yes, hello everyone. It's me, Bipin Basal, and in this project I am doing back end part. And that's it.
Thank you. Thank you. This time our theme is digital health strategy in rural healthcare, and also we'll add on this AI in healthcare and how it can be used in rural healthcare. So with that introduction, I would like to request Sudhin Kansakar to start his presentation.
If you could just let me know if you see the PowerPoint
Yes.
deck.
Yes, we can see.
Okay, perfect. So hi everyone, my name is Sudhin Kansakar. Today I want to talk about this concept that I've been working personally on, which is a culmination of some of the work that I've done previously, which I feel is important. So as we know, half of the world can't reach a doctor, and this is also particularly true for Nepal, particularly in the rural areas. And there's two sides of it. One is we already know that 0.7 doctors are available per 100,000, per 10,000 in Nepal. But it's not only the availability of doctors, but it is actually a distribution issue. And the solution that I'm proposing right now is how can the AI revolution really help with getting access and equity in the healthcare sector. So the solution that I'm proposing, what we consider a health pod, where an AI-assisted LLM that has diagnostic elements to it, that is, first of all, solar powered, two, works offline in an edge computing way, that is not only doing a consultation with a doctor, but actually measuring specific elements such as vital signs, but other elements, and is accessible from a UI perspective, talking in Nepali and other languages. So combining those two will allow us to have triage capabilities in rural health, where 80% of the issues possibly could be triaged, where 10% of the issues can be escalated, where a doctor can come or a telemedicine solution can be provided. Now, as the technology has increased so much, AI does not require cloud. Obviously, it requires updates in intervals, but you can actually deploy AI on the edge where no internet is required, which is where I feel you can really increase access in countries like Nepal and others, where you might not have a full health system being developed. And so the idea that I'm trying to get to is we can build almost a primary care infrastructure where it's AI first, obviously with all the guardrails and everything. So it's not replacing doctors but it is actually augmenting it through the developments of LLMs and medical AI doctors. Just from my experience, sometimes I am using ChatGPT or cloud to do minor diagnostics within myself and my kids before I go see a doctor. So in the same concept, we're looking at how can we leapfrog the traditional health system triage by having AI first and then creating a robust escalation system where it might go to telemedicine second and then an in-person visit. And the technology is there available to make this happen. So as I spoke about it, edge AI is getting smaller and cheaper, so it is easier to develop more complex artificial intelligence on the edge, which does not require cloud systems. Solar is getting cheaper, so electricity-wise, and hardware is also getting cheaper. So it's something that before it was the technology that was being the bottleneck. Now it is about having the right people, the deployment, trust, and evidence that is required to make this work. And what we're envisioning is that these kiosks can be put in different towns and villages where a person can walk into the post, get their vitals, but also there are, I was looking at researching, there are like digital stethoscopes, camera technologies where these can be captured, and the AI would triage this on the edge computing and give them guidance on things that they should be doing, if they need to actually see someone and escalate. But they're not really kind of diagnosing, but it's more like triaging. And the reason is because this will provide access to a lot of people at a cheaper, at a very cheaper rate. But again, it can go wrong, right? Like, and we do need humans in the loop, and it needs to be audible. But this is something that we are able to do by making sure that the ethics and the way this is being developed is right from day one. So what this also allows us is, as I mentioned, to absorb the volume that a physician had never needed to be seen, and the scarce clinical time goes to cases that do. And so it's all about access and treating the right patient at the right time, and making sure that those patients that actually do need to see a physician gets to see at the right time, rather than everyone seeing the physician first time. So I wanted to keep this really light and have more time for question and answers. So I'll stop there and open it up to questions for people to ask on that front.
Yes, thank you. Thank you, Sudhin. Thank you very much. Anyone? Do you have any queries to Sudhin, please?
So just quickly recap. So there are three pillars that needs to be worked on. One is the AI aspect of it, which is the AI, the medical AI engine, which there are publicly available models that we can utilize, although those are in English. The thing that needs to be developed is more on the LLM, the Nepali LLM side, which I know there are a few firms that are doing this, but it's not as advanced on that front. From the medical technology side, we have partnered with some Indian firms to provide the diagnostic elements and on that front. But the key is to have the right system to deploy this, to pilot it, and execute it. This is where the highest risks lies on our front. But yeah, please, if there are any specific questions on that concepts or ideas, I'm happy to have a one-to-one call to discuss in more detail as well.
Thank you, Sudhin. Actually, I wanted to know if you have approached. Now there is innovation ministry, and last time I was also talking about innovation ministry that they are also wanting to push this startup programs like this. And Mahavir Kun, he has worked for telemedicine, digital health for a long time. So I think we can present this as a startup. I had he is advisor of this ministry, Sanjay, has just right. So Sanjay, you may not have listened to his presentation, but it's a very good concept that Nepal can utilize. So I think we can have a separate meeting for this.
Yeah.
So, can you please? Sanjay?
Yes, sir. Can you hear me now?
Yes, you are welcome. And Sudhin is here. He has a very good concept on using AI especially in rural health setting as well. So maybe we can have a separate meeting with him and start this as a startup.
Yes, sure. I think we can have the other further detailed breakdown in within the ministry as well. We can set up the follow-up meeting for that. Thank you, Dr. Uday. I'm so sorry, Sudhin, I couldn't see you. I missed the presentation, but we can catch you back.
Yeah, no worries. No worries. Sounds good. Perfect.
Yeah, thank you. So now we'll move to the next presentation. Next, I will be presenting on this digital health strategy for rural healthcare. I would like to make it very short. Yes. So, as you all know, our population is around 30 million, and 63% of the people are now have internet access. And this mobile user is almost 150%. So now most of our even rural people, they are very much used to with the mobile application and smartphones they are using, because many relatives of them are working outside and they are in frequent video conference and other chat with their family in mobile smartphones. So using smartphone for them now is being easier. So I think, but the use of smartphone in health or use of digital things in health is very rarely practiced. So we have this vision and strategy to start and improve use of this digital health and AI in rural healthcare. So for that, we have certain pillars that we have conceptualized is digital health and infrastructure and connectivity that should be improved. We should have health information system, and major problem is the interoperability. And government Ministry of Health has just issued policy on interoperability relating to fire profile and digital health services and telemedicine. Telemedicine has been very useful, especially for our rural healthcare, rural community. Data governance and security, privacy is always an issue, but I think it should be taken along with other development. And we should not be only stuck with the security and privacy problem. And of course, we have to have more workforce and capacity building. We have to train more healthcare professionals to be used to in digital health. So our geographic and topographic barriers, we all know there is very much difficulties because of the mountain and Himalaya regions. Even in Tarai region, the connectivity is very poor, and we have only fragmented and siloed health information systems. We have shortage of digital health professionals. Almost all healthcare professionals are not digitalized. They are not aware of this digital health development. We have very low digital literacy in remote communities and limited domestic digital health financing. Health financing has also been a problem. But of course, we have opportunities as well. As I said, 130% mobile penetration and strong mobile health base, strong political will. Many political leaders, they are asking for improvement of this telemedicine or even digitalizing their healthcare facilities. We have active development partners engagement, growing private health tech sectors, young, increasingly digital savvy population, and of course, APAN62 this foundation. We have proposed this three-phase implementation: foundation, integration, and transformation. So first thing is connecting this rural healthcare with different capitals of our states and even provinces. Another is connecting this DHIS to 100% coverage to all local governments, broadband connections, national telemedicine platform, and other registries. To the integration, we can have EHR in all district hospitals with AI support and national disease surveillance, digital health insurance claims. And third is transformation. First, start with EMR in local hospitals. Now, every EMR is powered with AI, and this to be connected with all three tiers of our government, and also help of these international connections. Next is foundation. So building the digital health base, we have to secure national data center, connectivity on broadband. We can also use offline first tools for different zones, remote zones, and hardware priorities. Next is information systems like DSIS2, master patient index, master facility registry, and national health data exchange. Also, legal and governments, we have to have clear acts and policies for digital health, for interoperability, and also for AI, of course. And our priorities should be national telemedicine platform, this mHealth, eHealth, and national health helpline. And phase 2 will be integration. For integration, we have to have this ESR in all district hospitals, shared health records, citizen personal health record, and of course, integrating with lab, pharmacy, radiology, and other subjects. We have to have advanced telemedicine and AI. Now, most of the EMR are coming up with AI-powered EMRs. We can start with different district level hospitals, health posts, and connecting them with provincial and zonal hospitals. Health data analytics. We should have national health data analytics centers, real-time disease surveillance, predictive resource planning tools.
Dr. Udaya,
Yes.
the slides aren't changed. It's on page 3.
So it's phase 2, yeah.
Okay.
Yeah, phase 2 health data analytics. So we should have all vertical program data. Is it in phase 2? Is it okay?
It's showing Nepal's digital health landscape.
Oh, then this slide is not changing. So is it changing now?
It's not in slideshow yet, and
Now it's 3-phase implementation roadmap.
no, it's Nepal's digital health landscape right now.
Oh. Okay, Rosen is looking at it. Now
Okay, but it's
3-phase implementation roadmap.
okay. It's not full screen, so just note that.
Yeah, down now we will go down. Yeah, and go down to backside. So is it changing now? Yeah.
Yes.
Yeah, thank you very much. So now phase 3 will be transformation, of course, with the AI-powered health systems, along with we'd like to connect it with SDG and universal health coverage. So I think digitalizing health system will also help in our SDG and universal health coverage target. So this is the investments summary that we have made. And governance and implementation, of course, there should be like the national level digital health coordination committee, and then digital health technical working group, different provincial health committees, and then local level committees, along with cybersecurity branch, financial teams, and to improve these financial gaps, low digital literacy, political transitions, and technological obsolescence. So these should be covered in our policy. So this is the key outcome target by 2031. So we will be reducing maternal mortality, UHC service coverage will be increased, faster diagnosis, electronic reporting from facilities will reach 80%, rural access to specialist care via telemedicine will reach 50%, and health data gaps and missing reports will be less than 5%. So ultimately, it should be monitored, it should be evaluated, and we should use this in learning. This is in our strategy, and the way forward is all three-level governments should be involved, and this financing, policy making, and implementation should be done by all these three tiers of governments. And we can also take help of development partners to align support to national priorities. We can ask private sectors to co-invest in PPP model and participate in the innovation fund. Also, civil society to advocate for equity, represent marginalized communities, and of course, health workers to work as champions in digital adoption, provide feedback for improvement. So this is the digital health strategy that Telemedicine Society of Nepal has proposed to be implemented in Nepal. So with that, I've finished my presentation. Thank you. If you have any queries, please. So maybe we can have discussion later on. I would like to ask Jivan Neopane to start his presentation. Jivan?
Okay, sure, sir. I'll start my presentation. So, is my presentation visible?
Yes.
So, hello, good afternoon, everyone. So during our first presentation, we presented the initial concept of using an AI-powered EMR system to support the telemedicine in rural Nepal. So, but today I'm very happy to share the progress we have made since then. The project has now moved from the conceptual steps to working platform. Today, I will briefly revisit the problem, explain the workflow we have developed, show the current system through demonstration, and finally discuss what we have planned to do next. So talking about the problem, Nepal has 77 districts and 81% of the population live in the rural area outside the urban cities. So according to Nepal Ministry of Health and Populations, the doctor to patient ratio is about 1 is to 1,724, and 65% of Nepalese people have the mobile subscription. That means they have their own mobile phone. So but what we have learned is that the challenge is not simply making the video calls. A video consultation alone does not create a structured clinical record. It does not automatically preserve the patient history, support follow-up, organize clinical records, or connect the consultation with a broader clinical workflow. So the problem we are addressing has three dimensions. One is clinical access, another is technology, and the third one is the workflow. So what we have built is we designed the platform around the three main components. The first is remote care. Patient should be able to connect the doctors through video consultation, either directly or with the help of local health workers. The second is structured EMR. Instead of consultation disappearing after the video call, the system creates visit-wise clinical documentations, including structured notes and ICD-11 suggestions. And the third is clinical supports. The system can support doctor matching, triage, referral information, and differential diagnosis and clinical coding. So, but one principle is very important throughout the entire platform. AI assists the clinician. It does not replace the clinicians. So the doctor remains responsible for all final clinical decisions. So we have two patient journey. The one is urban and another is rural. So for the urban patient journey, we are comfortable using the smartphone. The patient register and provide the basic information about themselves and the symptoms they have. And based on those symptoms, the system can recommend the appropriate available specialist. That means the best doctor will be recommended to them, and then they can book the consultations and joins the doctors through the video. So during or after the consultation, the system prepare a draft clinical record such as SOAP information. That means different sections like chief complaint, past history. So different medical relevant point that are discussed during the video consultations, and these are still in drafts. So once the consultation is completed, the doctors will review them, edits, and approves the information before it becomes the part of the patient records. So after they are being saved after they are saved by the doctors, they will be directly accessible to the patient through their mobile applications. So the next one is a rural health worker mediated journey. That means the patients will arrive in the health post, and the health worker will help them to register in our platform and add the details of them. And after that, they enter the symptoms why they come to the clinics health post, and then the specialist will be matched according to their symptoms. That can be done manually as well as it can be done with the help of AI also. So after that, one time will be fixed, and then teleconsultation with the doctors will be started in the presence of health worker in the device of health post. So after that, finally the notes are printed and shared by the doctors after the doctor's approval. So this is the rural workflow. And talking about the doctors, we have a separate platform for the doctors. So the doctors have their own web and the app wherever they can find comfortable. And then after when the health worker or any patients will register register a consultation with the doctors, and they can approve or decline simply with a reason, because they may be busy at that time, or they so that they can just approve or decline. After that, if they approve the consultation, they can join the consultation with the patient or health worker along with the patients, and then they will review the final EMR draft which will be generated by the AI, and they will make some edits, change, or if there are any mistakes, or if they need to add anything, they will just make changes. And finally, after the approval of the doctors, the differential diagnosis and ICD-11 codes will be generated. So differential diagnosis will be generated based on the past history of the patients, documents uploaded by them, which will be shown on the demo in the next few slides. So So the goal is simple. Nothing reaches the patient until the clinician reviews and approves. So after that, this is the overall blueprint of our systems. So we have a different platform. Doctors, health worker have webs, and there is an admin platform also. So patient have their mobile phones are also a web. So every like we have both web and app supported for every users. And after that, there are AI or clinical decision support system engines that will generate the clinical notes, and that will help in the doctor matchings. Pharmacy notes will be generated, lab notes will be generated, radiology notes will be generated, and finally differential diagnosis and ICD-11 codes will be also be generated. So after all the AI outputs will be reviewed and approved by the clinician before delivering to the patients. So this is the admin of flow demo. So in here they can just add the health post, add the health officers, add the doctors. So everything can be done through the admin portal, and they can edit, change, view the doctor details. Best they have we during the doctors, like we need to fill the different information of the doctors. So yeah, this is they can do. No, okay. So now there is another health assistant workflow where they can add the different vitals information, add the patient files, and they can write the symptoms. After that, after writing the symptoms, they can just have the AI suggestion of the doctors who are available, like cardio here. You can see you can choose the slots of the doctors, and then consultation can be booked. So after the consultation is booked, they can join the consultation along with the patients and the doctors. So there is option to do reschedules also. So after if I like in a few, like here we can see that they can join, like when the consultation started, doctor will join, the notification will pop up, and then the consultation will be started. This Ramesh Prasad Koirala is the health assistant. Along with the patient, there will be the patient also, and Rosina Srestha is the doctors. So after that, the consultation, after the end of the consultations, everything after the doctors review and approves, there will be the report here also, like you can see report PDF, so they can be shared directly with the patients. So next flow, there is the doctor flow. So doctor will join the consultations after the approval, and then after during the consultation also, they can view the what the patient, like patient details, what are the different documents they have uploaded. And after the ending of the consultations, doctor will end, and this different section will be filled automatically with the help of AI. And after that, there will be the they can edit, make a change. There will be the pharmacy orders, lab orders, radiology orders if there are. After the finalization, there will be the generation of the differential diagnosis and ICD-11 suggestions. So after that, they will also review those differential diagnosis and ICD-11 codings, and then they will be saved to the database directly. So this is the workflow of the doctors. Now we have a mobile app also for patient and doctors, because for urban we need just a mobile app for patient. So we created that. So we have this is the screenshots for patient flow in mobile app, and this is the doctor flow in mobile app. So it is easy to use. We have not it is very easy to use and designed by our UI experts. So talking about the barriers, like smartphones divide health, because the smartphone are not easily accessible by the elderly people in remote areas. So we mediate it with health worker will mediate them. And also regarding the usability failures, we have created the guided workflows so that they can be used easily. So only the since trust issues will be solved, since they will be every reports will be approved by the clinicians before delivering to the patients. And there is a dedicated health worker portal, so that they can manage the patient, and also they can communicate with the doctor. So we don't just rely on the patient portal only. So the another thing is digital literacy, that we will be solved by training and onboarding the health officers, doctors, patients during the piloting. So what we are going to do next is we will start the pilot at Uttar Gaya Rural Health Post in Rasua, and we will test privacy and security concerns. If we can change the like English supported website to the Nepali, so that the user can use them easily. So we will test the clinician usability, and also we will try to interoperability. We will explore that, because we can, if we can like integrate it in the existing system, then they will be like they don't need to keep separate patient records in our system. So that will be very easy for them. So we'll try to explore that also. So we have created the form to check the user acceptance test. So for different doctors, patients, health assistants. So we have created the form that will be the part of our study. So if there are any feedbacks regarding the platforms or real world readiness or any digital literacy and privacy, I'm happy to take your feedbacks and make our platform even better. So thank you very much.
Yes, thank you, Jivan. It's one of our grant project from APAN, and now we are going to implement this in our rural healthcare setting. So, and is there any queries or suggestion to Jivan? So if not, we would like to move forward. Here I can see Professor Sung Yong Lee from Kyunhee University. Professor Sung, can you please introduce yourself and start your presentation?
Thank you. Yeah, okay. Just hold on, please. Can you see the screen that I upload?
Yes.
Okay, great. Okay, thank you very much for your invitation. Also, I'm very much happy to introduce my research result, share with you. So today I'm going to introduce my research outcome and then share with you throughout this short presentation. Okay, my name is Sung Yong Lee, who is the Emeritus Professor of the Kyunhee University. This project is sponsored by the Korean government more than 4 years ago. Actually, this project is now running for 5 years. So this year is like last year to deliver the output. So 3 of the universities are participating in this project, and 3 more, like hospital, also work with us. Also, AI the medical related small startup company also joined to our project. Okay. The main theme of this project is to produce explainable, like medical report generation, as well as a kind of adaptable multi-agent system, like a platform. That means throughout the multi-agent system platform, we can produce some adaptable and personalized services, medical services, while explainable multi-agent system, we can produce some of the interpretable and explainable medical report generation. As you are well aware, conventional requirement in medicine should meet the evidence-based medicine requirement. Also, nowadays, there are many of the research undertaken in the area of the precision medicine. Therefore, we just interpret this precision medicine as a personalized medicine. That means based on the multi-agent system, how do we provide some of the customized services, okay, rather than, for example, analysis of the human's gene and provides appropriate services. Therefore, the term in here, precision medicine, are interchangeable to the personalized medicine. There are many challenges in AI in medicines. However, in this particular challenge, we are more focused on how do we achieve reliable and robust medical service system, as well as how do we achieve transparency and explainability. Therefore, based on to meet the medical requirement for evidence-based medicine, we try to develop explainable AI technology, also, to meet the personalized medical services, we try to develop multi-agent system to provide customized services. So ultimate goal of these two technologies should meet the current medical requirement. That means how do we mitigate hallucination that provided by current LLM environment. Then, very briefly, I'm going to introduce what is our explainable AI technology, and second one is what is our multi-agent system in the environmental of the on-premise environment. And then I'm going to show you some short a video clip to introduce our implementation of the multi-agent system, and then reach to the conclusion. In the explainable AI means, as you are aware, current neural models are very difficult to understanding what is the decision-making path. How do they make a decision? We don't know inside of the neural models behavior. Therefore, we call current neural model as a black box model. That's the reason many of the research undertaken to understanding how a neural model make a decision, okay? How do we get the transparency for the neural model? But actually, as you are aware, neural model is just inherently like a probabilistic model. Therefore, we cannot exactly catch up how this kind of decision making undertake. Therefore, one of our research team members are under developing the neural reasoning model and then published the 3 CVPR papers. The concept of this one is the just critical pathway identification technology. Based on that technology, we can obtain some of the heat map as well as finding out the interpretable output. So this neural reasoning goal is to develop analysis method for decision-making pathway and neural concept based on the interpretability in the medical neural network. Another technology we adopt to provide proofness as well as some of the causality relationship. So we adopt to the neural symbolic reasoning. Okay. The basic idea of the neural symbolic reasoning is identifying entity using neural network pattern recognition. That means based on the neural reasoning, we would like to obtain some of the neural network pattern recognition. After that, based on the symbolic reasoning, that is a conventional AI technology, we apply symbolic AI logic and semantic reasoning to uncover novel relationship. So, for example, if we ask to some of the neural model or only symbolic model, such as what is the shape of the red object like this, then only if we use only AI model or if we use only symbolic model, they cannot answer the correct answer. However, by means of the neural symbolic reasoning, we can get the answer. Okay, what's the shape of the red object? Red object, then the sphere is the correct answer. Therefore, based on this kind of the idea, we developed a system like the neural symbolic coherent reasoning implementation architecture. So for the retinal image and some of the background knowledge graph, we ask the question, is the blood vessel damage in the fundus image? Then our neural symbolic coherent reasoning output produce pathological causes as well as explainable medical report and also provide answer with proof. That means based on the pathological causes, we can understand what is the cause and effect for the medical report for this kind of disease? What are the evidence? Okay, what is the evidence for that kind of the input? That's the reason why we can ultimately obtain the causality as well as proofness medical report generation, and also based on the neural reasoning model, we can obtain the explainable medical report generation. Therefore, another one is, in addition to adapt to the conventional like API-driven LLM, we developed our own LLM based on the tuning OpenAI's GPT-OSS model with 20B parameter size. Our model, like so-called Blossom, performance is good to better than GPT-4o. Okay, this is somewhat out of date like record, but our Blossom model also works well in our project. So we combine two model with RAG into the Blossom and then finally generate explainable and explainable medical report generation. Also, our medical report generated by our system having a cause and effect, also proof of the certain disease. That is the our intermediate result of the how our medical services can produce explainable medical report generation. After that, to meet the personalized services, we have developed multi-agent system in the medical sector. So our basic principle is we adapt to the LLM-powered agent. So based on the prompt template, we can produce some behavior planning and reasoning and reflection that are needed for the multi-agent system platform. Okay. Therefore, we develop this kind of the multi-agent system architecture. Okay. Based on the due to the time limitation of this presentation, I'm going to just briefly turn on my video clip to explain what is the reflective multi-agent system architecture. So two key components in the multi-agent system is how do we planning of the multi-agent and how do we collaborate multi-agent multiple agent, right? Therefore, based on the LLM, we developed collaborate planner. Based on our LLM, we also developed multi-agent collaboration coordinator. So this one is the agent as some of the showcase. Our member of the consortium provide us heart failure data set in the real field. Also, we convert that data set into the knowledge graph. The reason for convert to the knowledge graph is that, as you are aware, hybrid RAG are very, very important to mitigate hallucination if we use the LLM. In that case, hybrid AI consists of the vector DB, graph DB, and time series DB, right? Therefore, in that case, okay, we have to extracting the knowledge graph from this kind of the raw data set so that we can easily understand what is the relationship between the data set, right? Okay. Also, another one is medical doctor provide us some of their knowledge bases. So rather than just depend on the guideline, medical doctor provide us their logic, okay, like this. So this one is a cardiovascular disease decision tree model. So in order to easily develop this kind of the model, we developed our iterative decision tree authoring tool. That means intelligent authoring tool. By using intelligent authoring tool, we can easily develop this kind of the decision tree model, and then regard that as a kind of the knowledge basis, right? So we set up some like a scenario like that. So this kind of contact appeared on my video clip. So I'm just skip. And this is the screenshot of the like our multi-agent system user interface. So I'm going to briefly introduce you what our multi-agent system works well.
I'm Sun-Young Lee, Principal Investigator of the Explainable Logical Reasoning for Medical Knowledge Generation project. In Phase 2, as a moving target, we are developing a reflective medical multi-agent system for personalized medical services. This is a multi-agent system built on large language models. The reflective multi-agent system architecture has these key components. The agent framework handles prompt-based planning, elicitation, reflection, and inter-agent collaboration. Knowledge governance links the legacy, vector, and graph databases to manage high-quality medical data. Context management secures consistency, and safety and alignment secures safety. The evaluation suite evaluates the outputs. Now I demonstrate Mass Builder, the core operating environment of the reflective medical multi-agent system. Centering on the main navigation bar on the left of the screen, I will guide you through the platform. Each module plays its own role in generating explainable, trustworthy medical reports. The dashboard acts as the control tower for the entire system. It provides a comprehensive workspace where you can see, at a glance, the active agents, deployed workflows, and external tool connection status through intuitive indicators. Scrolling down, the agents module is where specialized medical roles are configured and managed as AI agents. Here you create and configure specific agents such as medical entity recognition or cardiovascular diagnosis. These agents handle complex clinical tasks. Now let's look at an actual multi-agent scenario. This scenario covers health information and cardiovascular disease services. First, the user enters a detailed medical query and then runs the workflow. When the user enters a medical question, the collaborative planner and multi-agent coordinator analyze it. Then specialized agents collaborate to generate a trustworthy, explainable medical report. For example, the cardiovascular diagnosis agent analyzes the user's symptoms for an initial diagnosis, and the coordinator consolidates all results for final delivery. In the detailed execution, as the user enters the question, the workflow progress is shown in real time on the right side of the screen. First, the planner analyzes the question and defines the goals, then calls the multi-agent collaboration coordinator to invoke the agents. On screen, you can also see the plan generated by the collaborative planner. You can see the medical entity recognition agent being called and successfully extracting the medical entities from the question. On the left, the step card shows the agent extracting symptoms, medication, and age from the patient's own words. The retriever agent gathers the relevant clinical guidelines. You can also see the extracted keywords on screen. Next, the cardiovascular diagnosis agent produces a diagnosis from the patient information and guidelines. This diagnosis is generated from the patient information and the clinical guidelines and includes a variety of attributes. Here, the diagnosis agent evaluates the symptoms against the retrieved decision tree rules and guidelines. It then derives a confirmed diagnosis and returns the result to the coordinator. The explanation agent organizes evidence and management strategy references. It uses 3 tools to produce an evidence-based explanation. This explanation gives an overview of the patient's profile, symptoms, history, medications, and vital signs. It also covers the cardiovascular risk factors, the management strategies, the clinical conclusion, and the supporting references. Here you can see the result generated by the LM explanation agent. The coordinator now collects the explanation and the confirmed diagnosis and prepares a comprehensive report for the user interface. And these are the reference materials. After that, the health literacy agent uses 5 tools to reorganize the content. The result is a form that ordinary users can understand more easily. The medical entities are then integrated with the generated explanation and returned as a friendly summary of diagnosis, treatment, and lifestyle advice. Through this process, a very comprehensive result is generated, and the workflow runs to completion. Now, let's take a closer look at the medical report the system generated. The finished report turns the initial symptoms into a tailored care plan. The completed medical report includes a disease explanation and heart care methods. It also covers diet and lifestyle improvement recommendations. This report also includes a dietary recommendation to eat plenty of fruits and vegetables. It also advises quitting smoking to improve the patient's condition. Our future research plans are as follows. We will expand the one-to-many structure into a many-to-many multi-agent structure. In addition, we will develop a more efficient, lighter operating model with lower system latency. We will also extend the platform to the energy domain, where multi-agent systems can deliver energy services, such as energy bidding. Thank you.
Okay, thank you very much for your listening. That's all I have on today. Do you have any questions?
Thank you. Thank you very much, Sunil Lee. Is there any question, suggestion for him?
I have one quick question.
Yes, please introduce yourself.
My name is Abhimanyu. I'm based in Nepal. I'm a member of Telemedicine Society of Nepal as well as Digital Health Forum. The question is, so you're using something like LLM as a judge to explain the result. Am I correct? Am I in the right path of understanding?
Okay, LLM is used for the multi-agent system as a in some sense as a judge, right? And the supervisor. Right. Okay, and then also making a plan how different multi-agent system having a sequence to establish the workflow to treat some kind of the medical tasks, right? So,
that's very interesting. I was also thinking, but do you fine tune it further down the road? I mean, because eventually you have to validate this with real life results and have actually a doctor patient, go back and forth that has this really generated the right amount of detail, even if it has generated the correct answer. For example, if somebody says eat nuts, then is it eating nuts as in omega-3 or something, are you going down that path yet?
Yeah, that's good questions, right? So the role of the LLM is, as you mentioned about, okay, how do we mitigate the hallucination, right? Our most important tasks in this particular services, how do we eliminate it? Not 100%, we cannot 100% eliminate the hallucination. Nevertheless, we can use the many different cocktail approaches such as RAG as you are aware, okay, based on the sophisticated design of the RAG, I think we can eliminate many of the artifacts. Another one is the LLM. The role of LLM is rather than using one LLM only one time, we have to duplicate and triplicate of the LLM. So one LLM generate some output, then the other LLM also validating and verifying under the guideline of the medical knowledge, which provided by medical doctors, right? Therefore, the role of the medical doctor are critically important to provide their knowledge into the our system throughout the hybrid RAG. That means RAG system itself also very important. Also, when we apply to the LLM, we do not just depend on one LLM, but we develop our own LLM as well as use the commercially available LLM to mitigate or reducing the correct output. That is our strategy.
Thank you. Thank you so much. Thank you.
Okay, thank you.
So thank you. So we should move to next presenter, Latika Giri. She will be presenting on AI for justice. Latika?
Hi, everyone. Is my screen visible to all?
Yes.
Sure. Thank you. Good morning, good afternoon to everyone present here. We've had some amazing presentations, and thank you for the invitation, Dr. Uday. I'd like to begin my presentation. The topic for today is AI for chest X-rays. No scan left unread. By scan, we are meaning to say chest X-rays of patients. I'm Latika Giri, representing my organization Second Eye, based in Nepal. The problem is that in rural hospitals, whether it be South Asia or Africa or even South American or Australian countries, we have hundreds of patients, but no radiologist on site. So we built a tool called Chest Guru to solve this exact problem, to help urban and rural centers with crowded patients or no radiologist on site, both problems. Chest X-rays are the most common imaging test globally, which is done globally, and interpretation is delayed or there are some inaccuracies due to the shortage of specialists. Also, we have absence of picture archiving and communication system, due to which we cannot use the layer of artificial intelligence. We deal with high patient volumes, variability in reporting. As a consequence, we have delayed diagnosis of essential diseases which are life-threatening, like tuberculosis, pneumonia, lung cancer, heart failure, trauma injuries, and even COVID complications. Additionally, in Nepal and in many countries, low to middle income countries, we rely on plastic films, which creates environmental waste. And if the plastic film is lost, patients have no archives and records to rely on. So they have to undergo repeated radiation exposure to bring out their diagnosis. So there are higher costs and barriers to AI adaptation. As a solution, we presented Chest Guru, which is a PACS-based first AI platform designed for Nepal. We have a digital PACS system as our core feature, which is affordable, lightweight infrastructure for secure storage, retrieval, and communication. It gives us AI-powered analysis, which detects 14 plus critical chest conditions, both communicable and non-communicable. We have explainable AI, which means the clinician can see where exactly in the scan the disease is present. The AI tool will make a colorful box representing different diseases, different color for different diseases, to show the clinician where exactly the problem is present. We also generate standardized reporting system for chest X-rays, and we have human in the loop. So physician can edit AI findings to ensure accountability. And we also have a decision support platform for healthcare workers in rural settings. And we also have a real-time dashboard that detects real-time outbreak detection for pneumonia, tuberculosis, and so forth. So we developed this by training our locally validated data sets. We obtained data sets from our partner hospitals, where we have also implemented the AI solution at Tribhuvan University Teaching Hospital. Currently, our clinical validation and adaptation is going on in Nepal and Ghana. There are several regulatory pathways which we have used to validate and use our tool in different local settings. And our tool has both cloud and edge computing, has DICOM HL7 standards, so we can fit our AI tool into different EMR systems that are used, and we have a secure compliance framework. So these are the diseases that were detected by our AI platform. These are the 14 different health conditions which are detected, and this is the prevalence of these diseases as detected in our tertiary care center in Nepal. This is the per pathology diagnostic accuracy metrics for 14 different diseases in a tertiary care population here in Nepal. We aim for early detection and reduce reliance on scarce specialists like radiologists, and we aim for faster turnaround of patients, and we also intend to make AI healthcare affordable for all. Our target market is district hospitals, diagnostic centers, and medical colleges. We have validated our AI tool and published it in MDPI Diagnostics Journal. We have trials going on in Ghana. Our AI tool has goals which align with Sustainable Development Goals number 3, 9, 10, 12, and 17, which makes AI affordable, rapidly usable, eliminating environmental pollution, and scaling through collaborations. It is not just a diagnostic tool, but rather a comprehensive platform which ensures there is health equity for all. So that's for now. If we have any questions, please feel free to share.
Thank you, Latika, for a nice presentation. So, is there any question for her? So, if not, we'll move to the next presenter. Next presentation will be from Ministry of Science, Technology, and Innovation. Sunil will be presenting.
Hello, everybody. Good afternoon. So this is Mr. Sunil Bania. So Sanjay sir told me just to attend this meeting, and then I had to go back and forth. So I think I missed some of the presentation, but like the presentation that I have been seeing, it's interesting. So let me introduce myself. I'm Sunil Bania. I'm currently working at Ministry of Science, Technology, and Innovation in Nepal. Is a ministry, is a secretariat at minister. So we do not have that much of, I do not have that much of slide presentation, but let me just briefly go like what this ministry is like and just like the idea that that has been pitched today was quite interesting, and then we will love to sit one to one to discuss about the ideas, and then ministry is willing to help any of the idea that has a commercial value. And since Ministry of Science, Technology, and Innovation itself comes on this domain, so I'm really happy to see such kind of initiations. Uh, so the Ministry of Science, Technology, and Innovation has just been established. It's been 2 months. So we are.
Sunil, do you have slides or?
Okay. I'll just present a quick structure of Ministry of Science.
Oh, your slide is not showing.
Okay, wait. I'm just. Can you see my slide?
Yes. Now we can see your slide.
Okay. So this ministry has just started. So it's been 2 months that the this. So right now we are working on making the law or act of the ministry, and the organizational structures of this ministry is like there will be a National Science, Technology, and Innovation Council, like the high level where the high level policy, strategy, roadmap, and investment priority will be fixed, and this will guide a Ministry of Science and Technology. On top of that, like Ministry of Technology would have different communities where uh, like under the Ministry of Science, Technology, and Innovation, there will be the different headings. Right now, the Ministry of Science and Technology will be operated in three divisions, where one division will be working on planning, policy planning, resource mobilization, and division, and another will be morely working on science, technology, research, and innovation, and the third division will be the administrative division. In like most of the science and technology and research innovations will come under the science, technology, research, and innovation divisions, where like under these divisions we have center of excellences, and we have the other agencies like NAS, NARC, and other research agency will come under this section. So like if you have any innovative ideas or any things, any research idea, then those ideas has to go through this division. Since this ministry is in initial stage, still we are discussing on the different policies, laws, and fixing the standards of the science in Nepal. So I would love to hear from you on this to come regarding like what are the things that we need to incorporate in our system. So like it will give meaningful solutions in days to come. I think so. The operational modality of science technology will be like will set the priority of a country on the basis of the priority. The research will be done, and research proposal will come on the basis of the priority, and then after research is applied, then it will go through the peer review, and then the grant is approved. So this is the ecosystem that we are trying to incorporate in this ministry. I think like this is overarching view of ministry, and since this is just a like initial stage of ministry, so we love to hear or get some feedbacks from you as well. And then if you have any idea, then please do visit our website, and you can you can post your ideas or your proposals over there as well, or you can directly come or come to the ministry and discuss with us. Thank you.
Sunil Banya. So is there any queries or suggestion to Sunil Banya? So if not, I can see Rajan sir from the venue. Rajan sir, how is the venue and how is APAN meeting going on? Can you please?
Uh, Good evening, sir. Are you listening?
Yes, yes.
Okay. At the venue, the meeting is already over. So we are attending these sessions from the hotel. And there was one healthcare professional management related topics during the day, and we participated in that session. And secretariat from Future University Hospital, she was there.
Okay. Okay, so say hello to everyone there. I can see Professor Khan as well. Professor Khan. Professor Surmo Khan. Okay, now then, now we are going to close the session. So all the presenters had presented very well, and it was very useful presentations, and most of them seems to be our future projects that will be very useful in our rural healthcare setting as well. So I would like to say thank you, everyone. And Professor Dr. Moriyama, would you like to say something? Dr. Moriyama? So if not, I think we can close the session and say bye to everyone. Can we take a photograph? So can you please come online so that we can take a photograph? Yes. Okay. Okay, thank you very much. So goodbye. See you in the next APAN meeting.
Okay, thank you. Bye bye.
Thank you. Bye bye.
Sharing